So now time is for a debate. I'm Mazda Biriyad, EP at Heartland. I invited Dr. Al-Khatib, Dr. Emmert, and Dr. Asir Watan to join me here. The debate going to be related to patients who had the CRT implanted for the primary prevention. And now it's at the time of gen change. Some of them, ejection fraction has improved. And Dr. Emmert going to tell us why we have to use a CRT-D with defibrillation at the time of gen change. Dr. Emmert is Assistant Professor of Medicine and Cardiology at the University of Kansas.
Good morning. Okay. Has everyone gotten their coffee? Because that's not an administratable way to get it. I have no disclosures. I thought we'd start with some debate ground rules. So, we are not debating the cost effectiveness of reimplanting an ICD or CRT-D. What's best for the patient is what we're going to talk about, not the economy. We are not debating about the patient who gets a device prematurely or with a reversible cause of their cardiomyopathy. Too soon after surgical or interventional revascularization, things like that. In a patient with a tachycardia-induced cardiomyopathy, they obviously wouldn't warrant a device. We are not debating about initial implant criteria. Those are pretty well established. We're not debating about the exceptions. We're debating about the individual patient. Okay, you should reimplant an ICD or a CRT-D in patients regardless of EF improvement at the time of generator change. We're going to briefly touch on primary prevention indications related to ejection fraction in particular. We'll briefly review how ICDs and CRTs are good and that they reduce mortality. Improvement of EF does not eliminate the risk of death or shocks through a device. We'll review how an ICD shock prior to generator replacement changes the patient's status to a secondary prevention patient. So we're talking about primary prevention patients, meaning they have not had a clinical event. If someone has a clinical event, they get treated, for example, they become a secondary prevention patient. So the rules are different. We'll talk about how EF is really just a surrogate. It is not the prognostic variable that we want to use when we want to track this information. New York Heart Association functional class, CHF, SCAR, cellular abnormalities, things like that are going to be more appropriate. EF may improve, but the substrate's still there. We'll talk a little bit about that. What does our guidelines for appropriate use care say about this topic? And who's taking the risk of being wrong? Do you want to take the risk of being wrong? Does your patient want to take the risk of you being wrong? Okay. Primary prevention of sudden death, some guidelines. In particular, we're going to touch on EF related. So an ischemic cardiomyopathy patient, greater than 40 days post-MI with an EF less than or equal to 35%, New York Heart Association functional class 2 or 3, and even class 1 if they have EF less than 30%. In the non-ischemics, EF less than or equal to 35%, functional class 1, 2, or 3. You'll see the class that they're, the class indication, 2B versus 1. The 2B applies to the non-ischemics that are class 1s. The class 1 obviously is what follows. Ischemic cardiomyopathy with an EF less than or equal to 40%, non-sustained VT, and inducible VF or sustained VT at an EP study. As far as CRT-Ds go, I tried to kind of put these all together. So there's class 1 indications, class 2A and class 2B indications, and then there's class 3 indications. Class 3 indications mean you shouldn't do this. Class 1 means you really should. 2A is probably, 2B is you can. You may have benefit. To make it very simply. CRTs are indicated in patients with an EF less than or equal to 35%, sinus rhythm with a Q restoration greater than 150 milliseconds, class 2 or 3, or ambulatory 4. So you don't want to do this in people who are acutely ill with class 4 heart failure in the hospital. For non-left bundle branch block patients, you have an indication that's a class 1, 2A indication if they're heart failure class 3 or 4 with that Q restoration. New York Heart Association class 2 is a 2B indication in the non-ischemics. And if their ES is less than 30%, they have a left bundle with a wide QRS of greater than 150, class 1. So to take that first indication, if you say I'm going to implant for a class 1 indication, class 2 indication, A or B, then basically left bundle greater than 150, functional class 1, 2, or 3 would qualify. Non-ischemic class 2 or 3 would qualify, or 4, sorry. CRTDs can be useful in patients with an EF less than 35% if the QRS is only 120 or over 120. And CRTDs in patients who are going to be undergoing a lot of V-pacing who meet the other criteria. Is an ICD therapy effective? So only 1 person in 20 usually survives an episode of sudden cardiac death. The other 19 people die usually before they even reach the hospital. Defibrillators, 19 out of 20 people will survive. So the efficacy of a defibrillator is approximately 98%. So it's an effective therapy. And these are things, obviously, I don't think we'll be debating. These are some major defibrillator trials for prevention of sudden cardiac death. The bottom few are secondary prevention. The upper ones are primary prevention. There are a lot of them, obviously. And to touch on some of the highlights, basically they reduce mortality 54%, 55 to 60%, 31%, significant reductions in mortality. CRTs have multiple benefits, in particular, a reduction in mortality and heart failure hospitalizations. So we don't really need to discuss what the indications are currently for defibrillator implantation or CRTD implantation. We don't really need to review whether they're efficacious or not. I'm sure we both agree on that. But what we're going to look at is more what we do with that EF going forward when it comes time to change the device. And what we've learned, for example, is that in people with sudden cardiac arrest, if the EF is over 40%, they still have an increased risk of sudden death. So this is a little graph that reviews, these are people with an EF of 0 to 30%, 31 to 40, 41 to 50, and even greater than 50. All of these people, as you can tell, still have significant risk of sudden death. And over 50% of all sudden cardiac arrest victims have an EF greater than 30% when they first have their event. So everybody doesn't have cerebral LV dysfunction or an EF less than 35% to begin with. Okay. Also looking at secondary prevention, there's an Oregon sudden unexpected death study. They looked at these patients with sudden death, and again, about a third that had baseline LV dysfunction only. It normalized over time, yet they felt that these people were still at risk of sudden death when they tracked them going forward. So even if they had normalization of their LV function, they still were at risk. If we look at some more primary prevention studies, the DEFINITE trial, which was a trial looking at non-ischemic cardiomyopathy and primary prevention, they did a long-term follow-up, and what they found was in 187 patients, they divided them into 3 groups going forward, groups where their EF got better, at least greater than 5%. We'll talk about how many were over 40. Their EF remained pretty much normal, or their EF might have gotten worse. If we look at the ones that got better, 32% had an improvement of their EF over 35%. Yet, the rate of ICD shocks, although it was reduced in the EF improved arm, it still wasn't reduced enough to be statistically significant. So these people still had a significant event despite an improvement of their EF. Okay. Another primary prevention trial, single center retrospective evaluation of 90 patients. A lot of these are going to be smaller trials, unfortunately, out of Minnesota. They actually took people who had a generator change, looked to see if they had an improvement of their EF going back before the gen change and then following them after. They found that 25 patients, or 27%, over the course of 6 years, had follow-up from their original implant with improvement, and their EF over 35%. However, these patients continue to have an increased risk of sudden death and or appropriate ICD therapies. The incidence of shocks was similar to the patients that had no change in their EF. So this actually went forward looking at these patients after they actually got the gen change, kind of the topic we're talking about. 36% had an appropriate ICD shock, even though their EF was improved. And 33 of those patients had the shock after the generator change, and that was the first time they got therapy. So they had not had therapy previously. They've been uneventful. Their EF was over 35%. They get their generator change, yet 33% of them still had an event. Study of 257 patients for primary prevention ICDs. 30% of those patients had improvement in their EF over 40%. 15% of them still received appropriate therapy despite having their EF improved. The rate of ICD therapy was unchanged despite improvement in their EF. When they looked at rationale or variables to try and figure out why that was, they came up with patients with a diagnosis of ischemic cardiomyopathy seemed to have it more commonly. If they had atrial fibrillation, despite having improvement in the EF, they still were prone to increased shocks, beta blockers. But what they didn't show was that the EF was a variable that made a difference. It was not a predictor of whether they'd continue to get therapy. And this just shows this in a table format. So rate of inappropriate therapies was the same, number of patients with inappropriate therapies. But if you look here, number of patients with appropriate therapies, no difference whether the EF was improved over 40% or whether there was no improvement. Okay, what about CRTs? CRTs is a little bit different because a part of the CRT defibrillator is the CRT, which is designed to improve LV function. And actually, there was a paper that was recently published this past year by my esteemed competitor, and they looked at 419 patients, so a smaller volume of patients over the course of 7 years, roughly. They estimated a 2-year risk of appropriate ICD therapy of 3% if their EF was 45%, going down as their EF improved. And what they found was if you looked at the primary prevention patients, if their EF was 55, so essentially normal EF, they still had a 1.9% incidence of events. The conclusion of the study was further study is necessary to determine whether such patients require CRT-D versus CRT-P therapy. That came directly from the paper. So in CRT-D patients, clearly they have improvement of EF, and they clearly have pretty significant reduction in their events and their mortality. But is it enough? At one point do you say, yeah, if there's one person that slips by. Okay, another similar trial or study looked at normalization of EF in patients with CRT-Ds. This was out of the Cleveland Clinic. And they called what they had super responders. And they took people with super responders with an improvement in their EF over 50%, and they tracked them going forward. And what they did was they tried to correlate their survival with age, sex-matched general population people. So almost like the insurance company will give you your actuary prediction. And what they found was that they had a very dramatic reduction in sudden death and mortality. But there were still some limitations. Okay. Does getting a shock or not getting a shock before their EF improved make a difference? So if someone never received therapy and they come up for generator change and their EF is now over 40%, does that make them less likely to need a device going forward? And the answer is no. 1,500 patients followed out of Germany. And they looked at the time to first shock. 13% of them had their first shock after their first generator change. 13%. And that was including the primary prevention patients, of course. The Altitude study looked at over 35,000 patients. 66% had no shock with their first ICD. Post-generator change, up to 30% nearly within 5 years had their first shock. So what does that mean? This just shows it in graph format. That means that patients who have not received a shock in the past, although their risk of having a shock going forward may be lower than if they did have a shock, it does not mean that they're not at risk going forward. So they're still at risk. Okay. This is the INSURE trial. Mostly it was secondary prevention, actually. And what they were doing was, again, following risks of getting appropriate therapy as the EF might have improved. They also looked at, are there any predictors? In other words, if the EF did improve, did it predict a lower risk for receiving shocks? The bottom line of this is, over 5 years, the incidence of appropriate ICD therapy for primary prevention was still 37%. 37% of people still receive therapy. Okay, we're talking about the EF. We're basing our decision on improvement in the ejection fraction. The ejection fraction, however, we know, lacks specificity as a predictor of arrhythmic events. It's a surrogate. Right now, it's the best thing we've been using to identify patients at an increased risk, but if we're going to make a decision about whether they maintain an increased risk, it's not the thing that's specific enough to tell us that. EF alone is not enough. So as a surrogate, it's not lending for prognostic information. It lacks that sensitivity. So the Oregon study, less than 50% of patients with a prior MI died suddenly with an EF less than 30%. So again, the people who are having cardiac arrest, their EF isn't down to begin with. From the MUST trial, MUST study, They looked at variables to try and predict people's risk going forward, primary prevention trial, and what they found was functional class had influence, inducible VT had influence, history of heart failure had influence. What you'll notice is, although EF may be a part of that, alone it was not enough to predict decreased risk. So patients with an EF of 30 to 40% had a total mortality and sudden death risk that exceeded some of the patients that were even less than 30%. So as the EF got better, some of these patients, based on these other characteristics, these other variables, still had a higher risk. So the EF isn't our predictor. Okay, limitations of EF for prediction. Again, they looked at other variables which we touched on already, so we're going to move on. Seattle Heart Failure Model. So they created a model in heart failure to find out what predicts future risk. They developed estimated survival of heart failure patients. They developed it during the PRAISE trial. They validated it. Factors that they found made a difference were age, gender, New York Heart Association and functional class. Again, what you're not seeing come up as a primary predictive factor is the EF. Okay, EF gets better. Does that mean that our structural issues are resolved? Well, if you go back to the Venn diagram of the way ventricular arrhythmias occur, you have substrate. Is the substrate tied to the ejection fraction? Of course not. We know patients who have had an extensive anterior MI, their EF may still be normal or certainly above 40%, yet they still have substrate that can trigger them into a VT or VF arrest. Improvement of EF does not mean improvement of substrate. It doesn't mean resolution of scar or myofibril disarray or alterations in the gap junctions, Dr. P, or inflammation that occurs to set things off. Other things that we know put people at risk for cardiac arrest, of sudden death, of receiving appropriate therapy from the device, does not resolve even though the EF may have. So again, despite improvement of EF, they're still at risk. Proven, myocardial scarring detected through an MRI was found to be an independent predictor, even more important than EF when it comes to adverse outcome. So they looked at patients with an EF of greater than 30% who had significant scarring, and if they had greater than 5% significant scarring by MRI, then their risk was the same, even though their EF was better, as though the patients had an EF that was below 30. So let me review that again. We know that people with an EF below 30 have an increased risk, at least based on the criteria we're using. This looked at myocardial scar by MRI. If they had scar greater than 5%, yet they had an EF that was over 30, their risk was the same as though their EF was less than 30. Regardless of EF, if they had significant scarring, they were found to be at an increased risk. Why is that? Because EF is not a good predictor. Patients with a less than 30 EF and minimal scarring actually had similar risk to patients whose EF was greater. Again, we're targeting EF, yet there's demonstrations through other modalities that we should be looking at, or that might be better surrogates to predict people's risk going forward. These are just the slides demonstrating that, or the images. Okay. What about CRT? Okay, so CRT therapy, what they've also found is that remodeling is a better predictor than EF improvement. So the extent of reverse LV remodeling varies. 22% can be considered super responders based on LV remodeling, not based on EF. Extensive reverse remodeling was related to a greater clinical improvement and functional improvement after 6 months of CRT therapy, and it, and not EF, was a predictor of their events going forward. If they had significant remodeling, regardless of the EF, they did better. Okay, so what do we think now, we collectively? What do our organizations think? What do the people who are establishing our guidelines think is appropriate as of 2013 when it comes to this question? So we're telling you our opinions, we're giving you our data. What's the rest of our community think? Okay, let's take a look. If we look here, we have patients receiving primary prevention device with an EF less than 35%. Their EF is 36 to 49, certainly better than 40%. It is acceptable, it is appropriate, it is indicated to change their device to a defibrillator. So the options when we look at appropriate use, the way they grade these is they give them an A for appropriate, an M means it might be appropriate to do that, or an R, it's rarely appropriate to do that. So our community, in establishing these criteria, these guidelines for us, have said if you have someone whose EF starts off less than 35%, they have appropriate indication at baseline, their EF improves, it's appropriate to put in the defibrillator at generator change. What about if it's unchanged? All appropriate. So there is no different, even if their EF was over 50%, quote, normalized, it still is appropriate to replace their device with a defibrillator. If we look at CRTs, CRT said similarly it was appropriate to replace them with a CRT defibrillator, although maybe we'll find it's appropriate to just use the P, based on some of the earlier trials we talked about. Maybe. Okay. Once a patient has received a defibrillator and they have a ventricular arrhythmia subsequent to that time that gets treated, they are secondary prevention. They are not a part of what we're talking about. We're talking about replacing someone primary prevention. So the approach is going to be different. If they've had an event, there isn't justification to not put a device back in. Okay. Part of our issue, which is something we've all been struggling with for decades now, is we don't have any test that determines a single individual's risk. We have studies that have looked at a collection of people with similar characteristics. And when I talk to patients about primary prevention and getting an ICD, I have to tell them, I can't tell you what your risk is. I can tell you what people like you, what their risk is. I can tell you that people just like you benefited, had a significant reduction in mortality, but we don't have a test that assesses your individual risk. And that's problematic. So, what are some tests that we can do? Well, we can look at their EF. We look in T-wave alternans, signal averaging, baroreceptor sensitivity, take them to the EP lab. None of these things by themselves or even in some collective fashion have been adequate enough to predict people's risk going forward at an individual level. So what's the best tool for the job? Well, that's one way you can clean your cow, I guess. Only in Kansas would you see that, I'm sure. Okay? Despite the large number of clinical trials done, there is not enough concordance among any of the data at the present time to say we have a single test that predicts or influences outcome, including EF improvement. It doesn't assess an individual's risk. So who's taking the risk of being wrong? Right? Do you want to take that risk? Do you want that phone call at 6:12 a.m.? So here is a part of the issue. We have legal issue on one road, ethical issue on the other. You want to do what's right for the patient. You don't want to make that an issue, right? You want legal and ethical and doing what's right, on the same side, going the same direction. Okay, who's taking the risk of you being wrong? Well, is the patient taking the risk? This slide says, I admire your persistence, doctor, but face it, you've lost the patient. You can't afford to be wrong. So if we're going to make a decision not to reimplant this person's ICD when previously we identified them to have an indication for it, you can't afford to be wrong. So you should reimplant ICD CRTDs in patients regardless of EF improvement. We know they reduce mortality at a baseline. We know the EF improves less than 30% of the time and based on certain studies. We know that once they're treated, they become secondary to prevention. They're completely different regardless of what happens to the EF. We know that improvement of the EF does not reduce or eliminate, it may reduce but doesn't eliminate their risk of future shock or sudden death. We know it's not a good predictor. By itself, it doesn't tell us what their risk is going forward. There are other things that have already been shown to be better. MRI scar, a collection of constitutional things. The EF may improve, but we know the substrate is likely still there. And who's taking the risk of being wrong? Don't you take the risk. Don't let your patient let you take the risk. I do stay in shape. This is the shape I stay in. So we don't need to accept the status quo. We're up here arguing whether EF is a good marker of what to do going forward. We don't need to accept the answer as that's not a good marker. What we want to do is look for an individual, a test that will give us an individual assessment's risk. But in the meantime, we should replace their device regardless of whether the EF improves. but we still need to be looking for that individual tool. Thank you.
Okay, second part of the debate, Dr. Al-Khatib will tell us why these patients, they don't need to get the CRT-D or the ICD. Dr. Al-Khatib is Assistant Professor of Medicine and Associate Professor of Medicine and Cardiology at Duke University. Thank you.
I love debates. Good morning. It's a pleasure to be here and to have the opportunity to debate my colleague, Dr. Emert, on this interesting topic. I have no financial relationships with industry, and before I delve into the debate, I just wanted to show you a brief glimpse of how I'm feeling like right now. So last week, I sat down to start working on my slides for this debate. And as an evidence-based and data-driven clinical investigator, I started by asking myself the question of what do we actually know about this topic? Okay, well, the main clinical trials of primary prevention ICDs did not tell us anything about ICD replacements. Even the long-term outcome data that came out of MADE-2 and SCEDHAFT looking at mortality didn't mention anything about ICD replacements. That's also true of the main clinical trials of CRT-Ds. They definitely gave us a lot of helpful information, but unfortunately, we really didn't learn anything about device replacements from those trials. So I diverted my attention to the guidelines. Now, I fully recognize that in the absence of data, the guidelines cannot offer any recommendations regarding what to do with regard to replacements, but I thought maybe I'll find some mention of what to do at ERI, maybe some guidance, maybe highlighting the uncertainty in our knowledge of what to do when devices are at ERI and the ejection fraction improves. Well, much to my surprise, I didn't find anything mentioned whatsoever in the initial guidelines that were published in 2008, as well as the focused update of the guidelines that came out in 2012. So like Dr. Emert, I actually reviewed the appropriate use criteria document because in the absence of data, you really have to check and see what the experts think. You resort to expert opinion. And I have to, from the get-go, make it very clear that the subject of this debate is not patients who started off with a primary prevention ICD and ended up receiving appropriate ICD therapies in the setting of not in the setting of a reversible cause. These now become secondary prevention patients. And these are not the topic of this debate today. What we're talking about are patients who start off with a primary prevention device and who do not receive any appropriate therapies. So let's look at what the experts think here. So if you look at where they say patients started off with a primary prevention device, and now the device is at ERI, they haven't received any therapies, and oh, by the way, now the device is at ERI, and we need to make a decision as to whether to proceed with device replacements or not. And you see here the 6 and the 5 if the EF has improved. And now that falls into the category of maybe appropriate. But to me, it highlights the uncertainty surrounding this topic. Okay. We move on now to the CRT-D side. And as my colleague pointed out, if you look at these people where the ejection fraction improves significantly, the appropriate use score is also in the 5 to 6 range if you are able to, replace the CRT-D with a CRT-P. Again, they're telling us that this may be appropriate, but again, it highlights the uncertainty surrounding this topic. So here's my argument number 1. Clearly, we have no robust data on ICD or CRT-D replacements. So if you ask me, should a patient with a primary prevention ICD or CRT-D and subsequent improvement in LVEF to greater than 40% get a defibrillator at ERI, in the absence of robust data and as an evidence-based person, I'm going to have to tell you, I don't know. So what I would like to do is to focus on what I do know. So I completely agree that we have very rigorous data showing us that ICDs save lives. That definitely was very well demonstrated in the MADE-2 trial as well as the SCAD-HEF trial. And in fact, our group analyzed the ICD registry and compared the outcomes of patients in the ICD registry with patients receiving an ICD and medical therapy in MADE-2 and SCAD-HEF. And we very nicely demonstrated that patients in the ICD registry had a similar survival to patients who received an ICD in those clinical trials and better survival than patients who received medical therapy in the clinical trials. So that evidence is very well demonstrated. But let's actually focus on the EF data from these trials and from our analysis. So as you all know, these studies allowed an ejection fraction of 30 to 35% and less in the clinical trials, up to 40% in MUST. But if you actually look at the ejection fraction of patients enrolled in those trials, okay, you'll see that that ejection fraction was well below 30% in all these trials except for MUST. And in fact, our group recently analyzed patient-level data from these 5 randomized clinical trials, and we found that only 389 patients had an ejection fraction between 30 and 35%. And only 184 had an ICD. So do we actually have data on patients getting an ICD if they have a better EF than what we saw in the clinical trials? So here's my argument number 2. There are no robust data on ICDs or CRTDs in patients with an ejection fraction of greater than 40%. And my colleague showed you the results of this secondary analysis of the MUST study. And this is actually key, but I'm going to argue about it from the other angle. So, okay, great. We look at all these different variables that MUST looked at, and I completely agree. Even patients whose only risk factor of EF of less than or equal to 30% have a predicted 2-year arrhythmic death risk of less than 5%. So I completely agree that there are other factors to take into account, but this doesn't mean that every time you take these factors into account, you end up with the conclusion that the patient needs an ICD. You may actually end up with the conclusion that they don't. And so my argument number 3 is even in patients with an EF of less than 30%, the EF is not enough to define someone's risk of sudden cardiac death. And as I said, if you take these other variables into account, you may end up with the conclusion that they may not need to be replaced with a defibrillator. And clearly here, the ejection fraction, it does not predict cardiac mortality when you're talking about more preserved ejection fraction. And my colleague actually showed you the results of this analysis. I'm showing them here just not to give them any importance, but just to highlight that even the study that we did was limited in many ways. It was a single-center study. It was a retrospective study. And that's actually an issue when you look at all the studies that looked at these issues. We don't have any prospective well-done studies looking at these questions. But at least in this particular one, as was pointed out, you'll see that in the primary prevention group, if you look at the patients who have a significant improvement in the ejection fraction, the risk of appropriate ICD therapy it goes down significantly. So I agree. What is an acceptable threshold here? What my colleague didn't actually show you is this graph here that was very telling. If you look at this here, this is for the overall population of patients that we looked at, and this is specifically for patients with a primary prevention indication. And since our topic is primary prevention, I'm going to actually focus on this diagram below here. And see how, as the ejection fraction improves, you see that the risk of appropriate ICD shocks goes down significantly. Okay, now follow-up was not very long. Maybe if we followed these patients up longer, we would have learned more. But again, this is hypothesis generating. I'm not saying that this gives us any answers, but it certainly makes us wonder what's going on and definitely pushes us to do more research on this topic. And in fact, some of you may be aware that Dr. Al Buxton, who was the principal investigator of MUST, and a couple his colleagues wrote a commentary in the New England Journal of Medicine back in 2012 recommending a new approach to ICD replacements. So what the document points out is that, when it is time to talk about changing out a device, you really have to look at everything. You have to look at whether the patient has developed comorbidities at this point that were not present when you implanted this device early on, 5 or 6 years ago. Things change. Patients get older. Patients get sicker. They develop comorbidities. The comorbidities that they have now may actually mean that their expected benefit from an ICD is much lower. So all of these things need to be taken into account. Of course, the patient had lived with an ICD, they've had experiences with it, so you need to take into account their past experiences, their preferences, so that definitely needs to be looked at, advanced care. But I really love these recommendations here, where they talk about that we have to have a task force to establish guidelines regarding the clinical, ethical, and logistic aspects of ICD replacements. And of course, you can't have guidelines without doing the research. But I loved that document because it really highlighted the need for more research. And I'd like to share a couple of quotations from that paper where they said, conversely, in some cases, ventricular systolic function may improve so dramatically that a patient may no longer be at identifiably heightened risk for sudden death. In these cases, replacement of a primary prevention ICD may not be necessary. And again, they say the lack of empirical data on outcomes after ICD replacement has prevented the development of firm recommendations to guide clinicians. And of course, the one piece that my colleague managed very nicely to avoid in his presentation is the adverse outcomes of ICDs. I mean, definitely ICDs save lives, and it's a great therapy, but one cannot not think of the adverse events and the adverse outcomes associated with ICDs, related to peri-procedural and long-term complications, related to all the ICD and ICD-lead issues that we have to deal with, inappropriate shocks. I'm sure several of you have had patients who have received 15, 20 ICD shocks, and now they're changed people. They have PTSD, they're anxious, they're depressed. And all of this needs to be taken into account, and of course cost, but I will not talk about cost effectiveness. And of course, there are some exceptions here. As we pointed out in a previous publication, it should be out that some of these implants, if you go in with a CRT-D or with an ICD, may be clinically appropriate. The guidelines indeed clarify that the ultimate judgment regarding care of a particular patient must be made by the healthcare provider and the patient in light of all the circumstances presented by that patient. So to conclude, I would say that there are no robust data on the outcomes of a primary prevention ICD or CRT-D versus CRT-P in patients with an LVEF of greater than 30 to 35%, let alone those with an LVEF of greater than 40%. LVEF is not a major contributor to the prediction of sudden cardiac death, less likely to be a contributor in patients with an EF of greater than 40%, so we have to take other variables into account, and those may lead us to conclude that replacing the device with a defibrillator is not the right way to proceed. Data suggests that of appropriate ICD therapy declines as the post-CRT EF improves, and the risk appears to be very low in patients with an EF of greater than 45%, but we really need more studies to confirm this finding, and prospective studies should be conducted of patients at high or low risk for sudden cardiac death who are eligible for ICD replacement to identify populations that are likely to benefit. But of course, there are always exceptions. So let me finish here by laying out my rules.
Could you put up the beginning of my slide deck again? One of the first, I have the answer. Well, truly load. So what I've learned from my esteemed colleague, who is an excellent clinician and a very dedicated researcher, is like any other researcher, we need and want more data. What we're talking about, and what you seem to fail to realize, was what the ground rules are. Right? So what we have to realize is what out here, what we all want to know is what to do today. Today, should we be reimplanting the device? anyone who is really scientifically driven, evidence-based driven, will acknowledge we need data. We don't have the answers, no question about it. And I didn't mean to mislead anyone otherwise. But with the information that we do have currently, it is not appropriate to not reimplant at this point. We know that people who have had substrate, improvement of the F is not going to be the predictor that tells you that substrate's gone. One of the things, or a few of the things that my colleague was talking about, was breaking the ground rules of this debate, which is not, and I appreciate you not talking about cost effectiveness, the original indication, right? That's not what we're debating. We can argue whether the criteria that we use currently for primary implant is appropriate. We can argue whether or not people who we're implanting device in today as de novo implants, if it's appropriate, but that's not what we're here to debate. What we're here to debate is what to do at the reimplant. We've committed to that person that they need a device. We can say we're wrong and not put it in, but then we're kind of identifying that we think they've had a reversible cause, right? Or the device went in inappropriately. And that's also not what we're talking about. We're not talking about who we decide doesn't need the device after all. What we're really thinking about in this question is, do we think their indication has changed? So we're taking for granted that we accept the original implant indication was appropriate. Now that we're going to take a look again and the EF is improved, is that enough to say there has been a change? So not whether the first implant was appropriate, because that's a whole different ballgame. That's a whole different way of looking at this. So it clearly is uncertain what to do. We clearly need more data, but the data that exists currently says EF 40% not a good predictor. CRTD patients with improvement in EF clearly reduced mortality, clearly reduced events in the small trials and data we do have available, but not elimination of risk. So today, with the information we have, and that's why we have the M under appropriate use. Maybe it's appropriate. A lot of what I was hearing was we don't have the data, we don't have the data. We don't have the data, but the data we do have, and to make the decision today, tells us we should reimplant.
I have my slides, please. Okay. So clearly there are no data, so why are we arguing? Is my first question. And at this point, we clearly cannot ignore the need for more data. So I think what I would like to do is to ask us to team up as a scientific community to try to address some of these questions. I think that would be so beneficial for our patients. I mean, now people just say, yes, we'll change it out and give them a defibrillator, but is this the right thing for our patients? I really think that we need to start working on this. Keep this one here. And, I have to say that, I absolutely believe in the benefits from ICD therapy. In fact, our group was one of the first groups to look at underutilization of primary prevention ICDs and gender and racial disparities. And we published all these experiences in different papers from different databases. And my belief in the benefit from ICDs led us to form the Sudden Cardiac Arrest Thought Leadership Alliance. And the goal of the alliance is to really raise the awareness of patients, the public, of other stakeholders around sudden cardiac death, around the benefits of ICD therapy. I'm definitely not opposed to ICD therapy, but what I'm asking is for more data. I definitely, when I want to do this clinically, I want to practice evidence-based medicine. So if someone is able to show me that what I think or do is not right, I will happily change, for I seek the truth by which no one was ever truly harmed. So that's what I would like us to do. And what I want to do is to end my note on my presentation on a very positive note. I actually see a lot of opportunities here for us to work together to maybe start thinking about research projects that can help us understand what do we do with these patients, because this question comes up more often than not. And I think it is important to have different stakeholders, get together, including the patients, some representatives of patient advocacy group, to start thinking about where do we focus, where do we start, what research studies do we need, And then hopefully once we have the research studies, once we have the data, we can come up with recommendations and indications and what have you. And so until then, I think you really have to have a discussion with the patient. You can't just decide on the patient's behalf without making sure the patient is very well informed. I think patients need to know that it's uncertain if they're going to get benefit from this other defibrillator. You know, you have to kind of take into account their past experiences with the devices, their preferences. I mean, we really need to talk to the patients and make sure that when we're making a decision, that we're making a decision with the patient and not for the patient. And so I'd like to conclude by this: let your mind take you to places you would like to go, and then think about it and plan it and celebrate the possibilities. So let's get started. Thank you.